with keratometry as
can be obtained. The difference is in their cross section and the placement in the cornea. The closer they are to the pupil, the more flattening they will induce, but the cross section has to be chosen in a manner so that the visual side effects are limited. The thicker the rings are, the more flattening they will induce. Now, intracorneal ring segments have often been thought of as something that can be done, but not something that everybody who treats keratoconus uses. We've had a very good experience with intracorneal ring segments, and this is a paper that actually helps you understand why intracorneal ring segments work well. Dr. Cynthia Roberts has given a hypothesis that the ectasia, whether it is post-LASIK or keratoconic, is caused by a focal problem. It's a focal biomechanical weakness. When there's a focal biomechanical weakness, you have an area which has a lower elastic modulus. This area tends to deform, and then it becomes thinner. A thinner cornea becomes steeper. So there is a cycle of stress redistribution. The peripheral area, or the area which is not a part of this focal point, may be normal. So this stress redistribution causes a perpetuation of the ectasia. So I'll just highlight a case which really helped me understand why the Intax is something that you should all adopt. This is a lady who's come to us with post-LASIK ectasia, which was post-pregnancy. You see her scan, the ectasia was not very much, and she was during her pregnancy and it was progressing. So we had done a simple cross-linking for her post her pregnancy. This is the first pregnancy. This is her in her second pregnancy. So despite cross-linking, the ectasia has actually progressed. This is her other eye. So her other eye had more advanced ectasia, and I had taken her up for cross-linking plus Intax in this eye. So this is her eye in her first pregnancy, and this is the eye in the second pregnancy. So you see that you have the same patient, one eye pure cross-linking, one eye Intax plus cross-linking. So Intax not only helps you with visual rehabilitation, it is perhaps playing a very important role in redistributing the stress of the focal point and making your cornea stronger. So it is a very important adjunct, and especially in cases of post-LASIK ectasia where cross-linking is in itself not sometimes as efficacious as it would be in keratoconus, Intax are important adjuncts. We normally use Intax in patients of moderate keratoconus. If a patient has very good vision, like 6.6 or 6.9 with glasses, these patients may actually lose some vision with intrastromal ring segment. So choose patients who have vision which is not improving beyond 6.12 with glasses. They have to have central clear corneas and a thickness of at least 450 microns at the proposed incision site. How do you select the segment? If you have a central cone, you have to depress it from both sides and flatten the central area. So you will choose two equally thick segments. If you have an eccentric, symmetric segments are normally therefore done in central cones. A way to find out if the cone is central is that the posterior float elevation highest point would be within the central 3 mm, and classically the spherical power will be more than the cylindrical power. So this is a case where you see we are using two symmetric segments. Asymmetric segments are used when the posterior float elevation point is outside the 3 mm zone. This is classically a more eccentric cone where you need to depress the, you need to flatten the cornea more with a thicker segment which is in the area of maximal ectasia, and there could be a supporting thinner segment or only one segment. So in such a case, normally the cylindrical power is more because it's an eccentric cone. This is an example of that. The preoperative workup also requires you to do a very good refraction, and the axis of the cylinder must be clear. Why that is so is because the spherical equivalent that you get by refraction is going to determine the thickness of the segment that you're going to use. And the axis that you get by refraction is going to determine the incision axis. Now this is a short surgery. We normally use the femtosecond laser to create the channels, and most of the complications which were listed earlier, it's not playing, so I think in the interest of time I'll skip it. We'll just go over a few cases now. This is a 22-year-old female. You see that she has a refraction of -1.5 sphere with -3.75 cylinder. But to calculate for the intacs, you must transpose it in a form that the cylinder is in the positive connotation. So after transposition, it is minus 5 sphere plus 3.5 cylinder. So such a case would require symmetric segments because the spherical component is more than the cylindrical component. The axis of sim case steep axis is 116 and the axis of positive cylinder is 120. Normally, if your refraction is accurate, you will always choose the refractive axis for the site of incision. If the cone is more advanced and you feel you are not very sure about your refraction because you get a lot of scissoring and you can't accurately predict the axis, then you go by the topometric steep axis. So this is the plan for this patient. Sphere component was larger, remember, so we are using symmetric segments. And this is the patient post-operatively, and this is the difference map with post-operative BCVA improving to 6.9. This is a patient who has had keratoconus and has been cross-linked. You can normally go for a segment which is one segment thicker post cross-linking because you expect a cross-linked cornea to actually flatten less. You should ideally do the intact segment with cross-linking or before cross-linking. We normally do it with cross-linking because that gives the maximal effect and convenience to the patient. This patient again has a higher cylindrical component and a more peripheral cone, and therefore an asymmetric segment or a single thick segment placed inferiorly will work very well. This is the difference map showing that the patient actually moves to a BCVA of 6/6 with glasses. Another patient where you see that there is a very advanced cone and there is a high amount of spherical equivalent. Such a patient benefits from the SK or the severe keratoconus segment. This is the thickest segment that is available, and two thickest segments are put in to give the maximum flattening effect. And you see there's a very significant flattening in the difference map, and the astigmatism has moved from 5.4 to 1.1. Now, while we try to decode it in terms of mathematics, unfortunately, the algorithms are not like LASIK algorithms, they are not mathematics. So you will expect some improvement, but some patients will improve more than others. Some patients will improve in 6 months and some patients will continue to improve even up to 2 years. So it's not as mathematical as a laser vision correction, but it is something that gives great benefit. This is a post-LASIK ectasia patient where normally a single segment does suffice. This is a 0.5 SK segment that has been implanted here. Now, like all cases, ICRS also has complications, and a range of 1 to 35% has been reported. In fact, when I entered my residency at RP Center, I said, do we do intrastromal ring segments? They said, we've tried it, they cause a lot of complications and we shall never do it again. So I never saw any intrastromal ring segments in my residency. But then we moved on and we had a different experience. So I think we can all learn, and with the femto platform and choosing the right case, you get very good results. Complications are usually easily handled. You must make sure that you insert it correctly. Do not create a false passage. We've had cases where we have created a false passage. I think the videos are not playing. This is the post-operative patient where we've actually perforated the cornea. The intacs, instead of being intrastromal, is in the anterior chamber. But the cornea is most forgiving and you can retrieve it simply by just going into the AC and removing the intact segment. This is what the patient looks like post-operatively. Sometimes you have an overlying stromal melt. If you have put the intact segment deep enough and distal to this incision site, must put it about 2 mm into the incision site to avoid extrusion, and you must put it at about 70 to 80% of the depth. Also, ideally, both the tips of the rings should not touch each other, because when they touch each other, they sometimes cause some torque, which will cause the twisting and the upward migration of the intacts and increase the chances of stromal melt. So both the segments have to be apart. This is the patient where you see there is an overlying stromal melt and there is some vascularization that is coming in. Such a case which is not responding, there has an excessive white cell reaction which is not resolving with steroids. We decided to remove the intact segment. The inferior segment was the one which was melted. So when we removed the inferior one, the superior was just the supporting segment. So we had to remove that also. But what was really unique was that when we removed this segment after a year, the flattening did not rebound, because possibly the scarring and the tissue modulation around that had caused some degree of permanent change, and the patient continues to do well. Keratitis is something we have seen and must be treated as an emergency. And however, you must distinguish sterile deposits which are commonly seen along these channels. They can be inflammatory white cell sterile deposits responding to steroids. You may also have lipid and calcium deposits for which you really don't have to do anything much. This is a white cell reaction with steroid response. In conclusion, intracorneal ring segments are very useful in the management of keratoconus and especially post-LASIK ectasias. Complications need to be identified and treated early, and you'll often have very happy patients who you can offer a great amount of visual rehabilitation and actually help with reducing their progression also in cases of post-LASIK ectasia. Thank you for your attention.
Thank you so much, Ritika, for that extensive presentation on intacs. While I request Dr. Shrish Kumar